Hello guys, welcome to my channel. Welcome back. I'm Julius Kwedhi MD, and today I'm going to start with a series of videos on surgical recall. Alright, before we get into it, please make sure you like, you share this video with your friends and colleagues, and subscribe to the channel. That will really help this channel to grow. Thank you so much. All right, we are going to begin with the operating theaters. A few etiquettes or a few mannerisms for behaving in the theater. If you want to sneeze, do not turn your head to the left or to the right or up and down. Just step back, take a step back, and then sneeze. The sneeze will flow through the side of your mask. All right, I'm sure everybody is well acquainted with masks now following the COVID-19. So if you want to sneeze, just take a step back. Do not turn to the left. Do not turn your head. Do not turn to the right. What's that? Lift your head or lower it down. Just step back and sneeze. If you feel faint, just say it. Don't try to be a hero. Don't try to be Superman or Superwoman. Just tell your colleagues in the OR that you feel faint and ask if you can sit down. All right? It's normal to feel faint, but to avoid feeling faint, make sure you always eat something before you go into the operating theater. All right. If it's your first time in the theater and as a student and you're walking in, make sure you introduce yourself. Or say that you are invited to scrub in to assist with the operation, and you can try to ask if you can if you can put on the gloves and gown, if you can scrub in, okay? But make sure that you wear your identification tag if you have one, okay? Some hospitals don't have ID tags, but if you have one, then make sure you wear it. What is contraindicated in the theater? What is it that you are allowed to? What is it that you are not allowed to do? Contraindicated means not allowed. Are nail polishes not allowed? Well, you can have, right? They are not contraindicated. You can have nail polish. But what about rings, earrings, and watches? No, those ones are contraindicated. Yes, rings are contraindicated. Yes, earrings are contraindicated. Yes, watches are contraindicated. They are not allowed. Do not attempt to go with them into the theater. So, in fact, as you scrub in, wash your hands, you are going to have to remove your earrings, your rings, and your watches before you scrub in, before you wash your hands. Okay? So you have to leave them somewhere in your locker. What are the non-sterile parts of you as the surgeon, as the assistant? Always remember that the non-sterile parts of you as the surgeon is your back, the back part of you, right? Your underarms, your armpits, that is. Under your armpits, your axillary fossa. Below the waist, right? Below the waist down is non-sterile, okay? By the pelvis going down, you are not sterile. Above the nipples, above the breasts, is a non-sterile region. Okay, so when you are don't, make sure that you don't touch these areas with your hands. Do not touch these areas with your hands that are don't in gloves. All right, even after having scrubbed, especially after having scrubbed. Right, and remember, you can button up your gown before donning the gloves. So if you have scrubbed in, you have washed your hands thoroughly, and then you are given a gown, you put it on, you may button up or tie your gown before donning gloves. All right, the caveat here is before donning gloves, before putting on the gloves. Okay, now as we said, this is the non-sterile region. This is the sterile region. Okay, here is the sterile region of you as the surgeon, right? as a surgeon, below the nipple, above the waist, right? And then the front part of your arms and gloves and your chest. This is the sterile region. Okay, that's a sterile area. So when you stand, this is the right way to stand, with your arms crossed on your chest, right? On your chest. This is the right way to stand while you're waiting for the operation to begin. When you don your gloves, you're going to don 2 pairs of gloves. You're going to don 2 pairs of gloves. And of course, one times of gown. 1 gown, 2 pairs of gloves. How will you don the gloves? All right, we'll explain that down there. So you will have 2 pairs of gloves, and then you will have worn your mask already, and you also wear your surgical cap. Okay, so you wear your gloves, you wear your mask, you wear your gown, and you wear your surgical cap. Okay, now about the gloves. First of all, you put on a large glove. So the first pair of gloves that you wear must be the larger size that you can fit. The larger size you fit, that's the first layer. And then after that, you wear the smaller glove on top, right? On top of the larger size, right? That's not a typo. It is first the larger size. First wear the larger size. If your larger size that you wear is 8 or 7, you put that on. If the larger size you wear is 8, then you follow that up with wearing size 7.5. This is especially for guys. And if you're a lady, you may first wear the larger size, which is size 7, and then the next size on top of that will be 6.5. Okay, it's not a typo. That's how it is. About the instrumental table, the instrumental table is the sterile field in the theater. Okay, let me repeat that. The sterile field in the theater, the most sterile place in the theater, the place in the theater where you don't have bacteria, as it were, are the instrumental table. Okay, I rephrase myself. The instrumental table is one of the sterile areas, so make sure that you don't touch. As a surgeon, don't touch. It's a sterile table. It's the instrumental table. It's a sterile field in the theater. The Mayo tray, as well as the anterior drapes on the patient. So, the Mayo tray, the anterior drapes on the patient, and the instrumental table. Those are the sterile fields in the theater. This is how the Mayo tray looks like, with the surgical instruments on top of it. Okay, so as for the Mayo tray, don't touch it. All right, don't touch it. Report it. Don't touch it without the permission of the scrub nurse. Okay, make sure you don't touch the Mayo tray without the permission of the scrub nurse or the scrub technician. Okay, let's proceed to the surgical techniques. All right, surgical techniques. When you are now performing the operation, you are now tasked with the task. You are now given the task to assist the surgeon, the chief surgeon, the surgeon who's carrying out the procedure, and you are tasked to help him visualize the operating field and such. So when you are asked to remove the blood, make sure that you dab. Do not wipe. I repeat. Make sure you dab. Do not wipe. Don't do it, because when you wipe, you'll end up removing the platelet plaque. So only dab, so that you do not remove the platelet plaques. Another thing, don't grab the skin with the DeBakey pickups, with the DeBakey instrument. Right? Why? Because the DeBakey instrument will end up crushing the skin. So make sure that you avoid crushing the skin. right, by not using the Debye key. What should you use instead? You should grab the skin using the toothed instruments that have teeth, such as the Adson and the rat tooth. Okay, that's because it is much better to cut the skin than to crush it. Now, to cut suture, when you are now about to finish your procedure, and you are now you have now sutured, what do you do next? What do you do next? Next, you make sure that when you are about to cut the suture, put the cutting hand, make sure that the cutting hand is resting on the non-cutting hand, okay? Make sure that the cutting hand is resting on the non-cutting hand. Moreover, after you have done that, you slip the scissors down to the knot. Slip the scissors down to the knot, and then you cant the scissors at a 45-degree angle. At a 45-degree angle, cant the scissors at a 45-degree angle in order to avoid cutting the knot. And then after that, yes, that's it. You cant the scissors at a 45-degree angle, and then you cut the knot to make sure that you avoid not cutting the knot. You cant the scissors at a 45-degree angle to cut the thread, okay, to make sure that you avoid cutting the knot. So when scrubbed, when you're scrubbed in and somebody else is busy suturing, when you're scrubbed in and somebody else is tying the sutures, ask the scrub nurse, you may ask the scrub nurse for a pair of suture scissors so that you are ready to cut the sutures in case you are asked to do so. Okay, next one. Now we are going to talk about, I'm now going to talk about surgical signs and triads that are very important in surgery. I'm going to talk about the Allen test, the battle sign, Beck's triad, Plummer's shelf, Carcinoid triad, Charcot's triad, and Schwostek's sign, as well as the Trousseau's sign. Okay, Trousseau sign. Okay, let's begin with the Allen test. The Allen test is a test that is used for checking the patency of arteria ulnaris. The Allen test is used to test for the patency of arteria ulnaris. Why do we want to check for the patency of arteria ulnaris? Because we want to place, because it helps us when we do the Allen test, as we check for the arteria ulnaris patency, this helps us to know where to place the radial arterial line. All right, this helps us to place the radial arterial line or the radial cannula, the radial arterial cannula in the right place. All right, it also allows us, it also guides us in being able to identify the artery for the collection of blood, for the arterial blood gases. Okay, now look at this. What is it about the radial arterial line? What is that? It's a cannula. It is used, it's an invasive, right? The radial arterial line is placed in order for us to be able to do the invasive arterial blood pressure, right? The radial line is for invasive arterial blood pressure, IABP. The radial arterial line is also used for the collection of blood for the arterial blood gas. So this is done on the hand, all right, on the hand at the wrist for collection of blood for arterial blood gases. Why do we do that? Why do we need to collect blood for arterial blood gases? Why do we need to do invasive arterial blood pressure? We do that when we suspect pulmonary conditions, also when we suspect acid-base disturbances, also when a patient has cardiovascular conditions, when a patient is in the ICU and needs to be monitored moment by moment. Okay, so the arterial line, the radial arterial line, is used when in a patient who has pulmonary conditions, cardiovascular conditions, is admitted in the ICU and need back-to-back monitoring of the blood pressure, as well as in the patient who has acid-base disturbance for monitoring. Yes, the Allen test, as I said, is also used for the collection of blood for arterial blood gases, which are also used in the same conditions as the radial arterial line. That is the respiratory conditions, ICU, patient who is in ICU, patient who has cardiovascular complications, as well as a patient who has arterial blood, who has the acid-base disturbances. Acid-base disturbances. All right. Now, the Allen test, how is it done? As we are testing for the patency of arteria ulnaris, here's the technique. So the patient first makes a fist, and then after that, you as the person performing the procedure, you occlude. You take your fingers, and then you occlude the arteria ulnaris, as well as the arteria radialis, right, at the wrist, with your fingers. So you use your fingers to occlude, to block the flow of blood in arteria ulnaris as well as arteria radialis simultaneously. And then after you have done that, the patient then opens up the fist. The person then releases his hand, opens up the fist, and as he does that, you release only the arteria ulnaris, all right? You release the arteria ulnaris, and then when you do that, you assess. As you release arteria ulnaris, you assess for the blood flow to the hand. You assess for the blood flow to the hand. Now, in 28% of the population, 28% of patients, that is about 3 in 10 people, they have the dominance, the complete dominance of blood flow in arteria radialis. Arteria radialis. All right, let's move on to the next one, the battle sign. Let's talk about the battle sign. What is it? The battle sign is used. We test for the battle sign, or let's say we assess for the battle sign. Excuse me, this is not the battle sign. This is the balance sign. The balance sign. All right, I repeat, the balance sign. The balance sign is used when we assess for the splenic rupture. When we're assessing for rupture of the spleen, or when we're assessing for hematoma of the spleen. So it's the same thing, right? Splenic rupture, the spleen has ruptured and therefore forming a hematoma. All right, especially in a patient who has had and who was involved in a motor vehicle accident, or a patient who has had abdominal blunt trauma. Blunt abdominal trauma, all right? Maybe was involved in a fight or was beaten up by some gangs or whatever. Abdominal trauma that may result in splenic rupture, you do a battle sign. You check for battle sign. What is the battle sign? In the battle sign, you percuss the right upper quadrant as well as the left upper quadrant. And when you percuss in the right upper quadrant, there is resonance. However, when you percuss in the left upper quadrant, there is dullness. This dullness is because of the accumulation of the blood. It's because of the accumulation of the blood, which has formed the hematoma in the left upper quadrant beneath the diaphragm, right? Beneath the, you know that the spleen is right in the middle of the 12th rib there. Yeah, in the middle of the 12th rib there, behind the 12th rib, extending a little bit below the 12th rib. So in that region will be dullness. There will be dullness. The spleen is usually difficult to palpate. Normally difficult, not so easy to palpate. You have to really do deep palpation. But when you do percussion in a patient who has had splenic rupture, there will be left upper quadrant dullness. However, there will be right upper quadrant resonance. Okay, next we go to the battle sign. All right, finally the battle sign. The battle sign We assess the battle sign in a patient whom we suspect to have had fractures of the base of the skull. All right? The patient whom we have suspect has fracture in the bone of the skull, in the skull bone, but the base of the skull bone. In a patient who may have also had blunt trauma of the head, or patient who has had even deceleration syndrome, deceleration injuries, was involved in a motor vehicle accident, baseball bat, has been beaten with a baseball bat or something like that. So in those patients, we assess for battle sign. And what do we see in a battle sign? We see that over the processus mastoideus, the mastoid process, we find that there is ecchymosis. There is an accumulation of blood over the processus mastoideus. In other words, there is a hematoma of tissues, or also known as contusion. There is a contusion, there is an accumulation of blood over the processus mastoideus, and it shows on the skin, okay, especially in people who have light skin. But yes, especially people whose skins are lighter, it shows much more perfectly. Okay, let's go to the Beck's triad. Beck's triad, we assess Beck triad in a patient that we suspect to have cardiac tamponade, in a patient who is suspected of having cardiac tamponade. Okay, and what is cardiac tamponade? Before we get to the to look at the triad, cardiac tamponade. For example, as you see here, we have the visceral pericardial sac. Right, the visceral pericardial sac here, as marked there. Now, look at this. In a patient who has had, for example, penetrating trauma, penetrating laceration, right, penetrating objects, penetrating objects over the thorax, or wherever really, that has then entered through into the pericardial sac, through the visceral pericardial sac, piercing the heart. Or a patient who has had an ischemic syndrome, who has had an ischemic heart disease that led to weakness in the heart wall, in the wall of the heart, that ends up causing rupture. Because of the rupture, or because of the cut in the wall of the heart, then you have blood that flows out of the heart into the visceral pericardial sac. And because of that, this accumulated blood, this accumulated hematoma, if you like, begins to compress, begins to push, right? Begins to compress the heart on either side, begins to compress. As you can imagine, when the heart is compressed, the space in the ventricles decreases, right? Meaning the blood takes in less blood and it pumps out less blood, so there is decreased cardiac output. Okay, so because the heart is being compressed, by the blood that is around it, and you then have decreased blood coming into the heart, and as a result you have blood that is backing up, backflow of blood to the lungs, as well as backflow of blood into the systemic circulation, right? On the right side of the heart, blood begins to back up this side. It also backs up this side, pushing over to the lungs, and then, of course, coming down to the right side. Then it backs up into the venous system. Blood backs up into the venous system. You have your inferior vena cava, you have your superior vena cava, and then the superior vena cava takes you to the jugular vein, to the jugular vein up in the neck. All right. So when the blood flow backs up not only into the lungs but also into the veins. Right. You have backup of, as we say here, as I've indicated here, blood backs up to the superior vena cava as well as to the inferior vena cava, and that backup of flow of blood also eventually gets to the jugular vein. Okay, jugular vein, and when it gets to the jugular vein, then this increases pressure in the jugular vein, which eventually causes the jugular vein to distend, and therefore it causes pulsation. Pulsation of the jugular vein. We call it jugular venous distension. Jugular venous distension, right? So that is one of the signs of, that's one of the arms of the of the Beck's triad is jugular venous distension, right? And then what else? Because as you can imagine, the heart is compressed. The pressure in the heart is increased, meaning there is increased systemic vascular resistance, as it were. There is the resistance, as it were, but that resistance is really because of the blood that is around the heart. Because of the blood that is around the heart, that is compressing the heart. So little blood is going out, meaning little pressure. There is little pressure. The heart is not pumping as it should. So the pressure in the heart is not as, the pressure exerted by the heart when it pumps the blood is low. That's why you have hypotension. That's why you have hypotension. And also, because the heart is not beating as excited as it would normally excitedly beat, you therefore have decreased heart sounds, which we call muffled heart sounds. So when you listen with a stethoscope, you have muffled heart sounds. You hear the heart sounds faintly, right? So again, the triad in Beck's triad is composed of jugular venous distension, which is caused by the pulsation, visible pulsation that is visible to the eyes. Moreover, another aspect of the triad is decreased or muffled heart sounds. Decreased or muffled heart sounds when you listen with the stethoscope. And also the other aspect of the Beck's triad is hypotension, that is decreased blood pressure. All right. Now let us move on to the next sign here. Bloomer's shelf. Let's talk about Bloomer's shelf. What is Bloomer's shelf? Bloomer's shelf, let me explain it here, is when you have a so-called shelf. You have a so-called shelf that is palpable, a so-called shelf that is palpable on the digital rectal exam. Digital rectal exam. So you do a digital rectal exam and you are palpating a shelf, a sort of mass. Okay? What mass is it? It is metastatic disease. It is a metastatic disease. It is a metastatic disease. It is a metastatic disease that metastasizes or that spreads to the pelvis. Right? Metastatic disease of the pelvis. All right. So it's when you palpate a metastatic disease in the pelvis that is usually located in the rectouterine pouch. Rectouterine pouch, which is also known as the pouch of Douglas. Pouch of Douglas, all right? In the pouch of Douglas, in the pelvis, you are palpating a metastatic mass, which is, as it were, on a shelf. So the rectouterine pouch is found in women. Okay, the rectouterine pouch, recto meaning rectum, uterine meaning uterus. So the rectouterine pouch is found in women, and so when you do a digital rectal exam in women, you feel a metastatic mass that is, as it were, on a shelf in the pouch of Douglas. On the other hand, in men, you palpate this mass in the rectovesical pouch. Rectovesical pouch. Recto meaning rectum, vesica meaning the uterine bladder. All right, uterine bladder. So this is found in men. In men, in the rectouterine pouch. So because there is no other structure between the bladder and the rectum, you only have the rectovesical pouch. All right. So let's look at it. So if this is your rectum here, as it is marked, then if this is your rectum here, then you have the, right, once again, if you have the rectum here, and then you have the uterus here, and then you have the bladder here. So the space between the rectum and the uterus is called the pouch of Douglas, or the recto-uterine pouch. Whereas this one is the vesico-uterine pouch. Vesico-uterine pouch. All right. Now, in that pouch of Douglas, there would be some metastatic process would accumulate in that place. The metastatic tumor would come and lodge in that place, as it were, on a shelf. And so when you do a digital rectal exam, then you feel it there as you push your finger, as you examine with the finger. That is now in women. So this is the abdominal side, this is the back, right? Whereas in men, right, as well as in men, so this is in women, right? So this is in women. Yes, this is in women. Yes, that is in women. And then in men, this is the abdominal side, this is the back, right, the spinal side. So you have your rectum here, you have your bladder here, and then you have this pouch here, right, the rectovesical pouch, where you find the metastatic tumor. Find the metastatic tumor, as it were, on a shelf, and you palpate that when you do the digital rectal exam. You feel it right there. Okay, now let us move on to the next. Let us look at the carcinoid triad. Carcinoid triad. What is carcinoid triad? Carcinoid triad, you find this in a patient who has the carcinoid syndrome. Carcinoid syndrome. In a patient who has carcinoid syndrome. Carcinoid triads are exhibited in carcinoid syndrome. And in a carcinoid syndrome, all right, before we look at the triad itself, in carcinoid syndrome, let's do a little bit of revision. Carcinoid syndrome is caused by metastasis of carcinoid tumor. Metastasis of carcinoid tumor. What happens? These carcinoid tumors they release vasoactive hormones. They release the vasoactive hormones. They secrete vasoactive hormones, right, which we'll see later, which we'll name later. And these carcinoid tumors, they are of neuroendocrine origin. They are of neuroendocrine origin, meaning they are from primitive stem cells, for example, primitive stem cells of the stomach. And so they metastasize and they lead to carcinoid syndrome, right? Let us look a little bit into the carcinoid tumors that release the vasoactive hormones. The examples of carcinoid tumors are the likes of adrenocorticotropic hormone, that secretes adrenocorticotropic hormone secreting carcinoid tumor, adrenocorticotropic hormone carcinoid releasing tumor. You also have the bronchial carcinoid tumor. You also have the pheochromocytomas. You also have carcinoid tumor of the lungs, carcinoid tumor of the GIT, carcinoid tumor of the thymus, carcinoid tumor of the pancreas, carcinoid tumor of the ovaries, right? Now, these carcinoid tumors, they are highly vascularized. They have a high supply of blood vessels. Now, and these carcinoid tumors, they are part of the multiple endocrine neoplasia syndrome, MEN1, right? They are part of the MEN1 syndrome. And they follow a rule of third. They follow a rule of 1/3. That is, 1/3 are multiple. A third of multiple endocrine tumors, a third of carcinoid tumors are multiple. They are more than one. A third of them are more than one. A third of carcinoid tumors, they are in the gastrointestinal tract, that is in the small intestine. Let me repeat this. A third of carcinoid tumors in the GIT are found in the small intestine. Okay. And a third of patients have secondary malignancy. A third of patients with carcinoid tumors have secondary malignancy, and a third of carcinoid tumors have metastasis. Let me repeat. The rule of thirds that is followed by carcinoid tumors is such that a third of carcinoid tumors are multiple, a third of carcinoid tumors in the gastrointestinal tract are in the small intestine, a third of patients with carcinoid tumors have secondary malignancy, and a third of carcinoid tumors are metastatic. They have metastasis. All right. Now, let us go on to look at the triad. The triad of the carcinoid tumor is such. You have the first arm is diarrhea. This diarrhea of the carcinoid tumor of the carcinoid triad is severe and debilitating. It also, and this is caused by tachykinins. All right, let me repeat this. The triad of the carcinoid triad is diarrhea, right-sided heart failure, and flushing. Okay, diarrhea, right-hearted side failure, and flushing. Diarrhea, right-sided hearted. Again, let me repeat. Diarrhea, flushing, right side heart failure, right-sided heart failure, and flushing. Okay, flushing, diarrhea, right-sided heart failure. Okay. About diarrhea, it is very severe and debilitating, incapacitating. Okay, this diarrhea is said to be caused by hormones that are called tachykinins. Tachykinins that stimulate the GI tract. What about the flushing? The flushing is also known as a red hot flushing of the face, which is caused by serotonin vasodilation. Serotonin is another is one of those vasoactive what did we say? One of those vasoactive hormones, vasoactive hormones that causes vasodilation, and as it causes vasodilation, it in turn causes red hot flushing of the face. Right. On the other hand, the right-sided heart failure is caused by the increase in the right atrial pressure. Right? Why? Why is the pressure in the right atrium increased? Let us look at that. It is also said that in carcinoid in the carcinoid tumor, in the carcinoid syndrome, in the malignant carcinoid syndrome, you can also find mitral regurgitation. Right? So you find two things in the metastatic carcinoid tumors, in the malignant carcinoid syndrome, malignant carcinoid syndrome, malignant carcinoid syndrome, malignant carcinoid syndrome. Malignant carcinoid syndrome affects the heart in such a way that you can have mitral regurgitation. What else can you have? You can have mitral regurgitation. You can also have right atrial pressure that is increased right atrial pressure. What happens? How does that happen? Let us look at how the pressure in the right atrium increases. So, in carcinoid syndrome, in the malignant carcinoid syndrome, you find that there is tricuspid insufficiency. The tricuspid valves are insufficient. In other words, there is tricuspid regurgitation. Right? Tricuspid insufficiency, meaning the blood is flowing back. It's flowing back into the atria, and is also flowing back into the superior vena cava, inferior vena cava, and the jugular vein. So you also have jugular venous distension. You can also have jugular venous distension because of the heart failure. But how do we get there? What happens in the tricuspid insufficiency. What is it that causes the tricuspid insufficiency? In the right heart failure, that is of the malignant carcinoid syndrome, you see that they found that there is white fibrous carcinoid plaques. So you have carcinoid plaques that are white and fibrinous that are lodged on the ventricular surface of the tricuspid valve, right? Let us look at the heart here. So if you have your heart here, quick diagram here, you have your quick diagram here, and then you have the aorta here, and then you have the valve like that, okay? Then you have the valve like that, all right? And then you have this tricuspid, so this is your mitral valve there. All right, so let us say this is your right atrium, this is your left atrium, this is your this is your left ventricle, this is your right ventricle, right? And these are your mitral valves, and these are your tricuspid valves. Now, in malignant carcinoid syndrome, you'll have these white fibrinous carcinoid plaques that are deposited on the ventricular surface of the tricuspid valve, meaning they will be lodged here inside on the side of the right ventricle, right? On the side of the ventricle, not on the side of the atria. On the ventricular surface of the tricuspid valve, the white fibrinous carcinoid plaques are lodged, and those white fibrinous carcinoid plaques end up causing the tricuspid valves to adhere to underlying right ventricular wall, all right? Because of that, because of these lodging, they end up adhering to the wall of the right ventricle. The tricuspid valves adhere to the wall of the right ventricle, the underlying wall of the right ventricle, right? So the tricuspid valves, they end up attaching here, right? You know, there are three cusps. You know, there are three cusps of the tricuspid valve. That's why it's called tricuspid, right? So there are three cusps of the tricuspid valve, right? So they are attached, they end up adhering to the underlying right ventricular wall, and as a result, it's as it were, it stents. It's as if you have a stent. It's as if you have now a stent, and the tricuspid valves are no longer closing properly, right? It's as if you have the stenting of the valve. So the valve is stented open. So there is a stenting valve of the valve that keeps it open. And so when the heart contracts, then the blood, instead of just going into the pulmonary artery, it also flows back. Right? Blood flows back. And then when the blood flows back, that causes the pressure in the right atrium to increase. The pressure in the right atrium increases, right? Remember we said here that in the right-sided heart failure, there is increase of the right atrial pressure. So that atrial pressure is increased because of the backflow of blood from the right ventricle to the right atrium. Why? Because the tricuspid valves are stented open. They are open. Why? Because the white fibrinous carcinoid plaques have lodged on the ventricular surface of the tricuspid valve, which in turn causes the tricuspid valves to adhere to the underlying right ventricular wall. So the tricuspid valves are stented open. And as a result of this stenting, you now have the tricuspid annulus dilated, right? So when you have the stenting valve, the stenting of the valve is stented open, you now have the tricuspid valve. This causes the tricuspid valve annulus to be both distended and deformed. The annulus of the tricuspid valve is dilated and deformed. The tricuspid valve annulus is dilated and deformed. Moreover, the valve leaflets are stretched. The valves of the tricuspid leaflets are stretched. The valve leaflets of the valves are stretched. The valves are stretched, right? Stented and dilated and deformed lumen or annulus, right? That's why, because of the valves that are stretched and you have dilated and distended and deformed annulus, that's why you have the regurgitation. That's why you have the regurgitation of the tricuspid valve, all right? So that is the Charcot triad. And this all happens, why? Because you have these are all these right side heart failure, diarrhea and flushing. These are systemic manifestations of the multiple of the malignant carcinoid syndrome. Why? Because these hormones, they have escaped hepatic degradation, so they were not destroyed in the liver. As you know, the liver acts as a detox. It's a place where you detox your body. It's also a place where all the harmful substances are removed, of course, detoxification, right? And so these hormones, they escape that degradation in the hepar, and therefore they manifest. Their systemic manifestation is such that there is diarrhea because of the tachykinins, the flushing caused by the serotonin, and the right side heart failure caused by these plagues that cause the tricuspid valve to be dilated and causing regurgitation. Okay, now let's look at Charcot's triad. Let's look at Charcot's triad. Okay, this is also a triad. Before we look at the triad itself and make sense of it, as we read it as Charcot's triad. Before we make sense of the triad, let us start there. What is the triad? What is Charcot's triad? The Charcot's triad is used to assess for cholangitis. We use Charcot's triad to assess for cholangitis, which is the inflammation of the bile duct, right? The bile duct. Of course, you know that you can. This is common in female 40 fat, right? Your mnemonic there, female 40 fat, female in women who are usually older and fat. Or did I say blonde? Fair female 40 and fat. Fair female 40 fat. This is the usual clinical picture of cholangitis. Okay, now what is cholangitis? What is this inflammation of the cholang? It is inflammation of the ductus choledocus. Cholangitis is inflammation of the ductus choledocus. Why? Why is the ductus choledocus inflamed? In the ductus choledocus, you would find choledochal obstruction. When there are stones, especially caused by choledocholithiasis, when you have choledocholithiasis, meaning stones, lithiasis means stones, choledochol means the ductus choledocus, right? So when you have stones in the choledochal duct, in the ductus choledocus, that causes obstruction. But this obstruction can also be caused by tumors, parasites, and stents that are placed in the ductus choledocus. All right. So when you have the obstruction of the ductus choledocus, this can cause two things. Can cause gallstone pancreatitis, gallstone pancreatitis. It can also cause acute cholangitis. So choledochal obstruction can cause gallstone pancreatitis. Choledochal obstruction can cause gallstone pancreatitis as well as acute cholangitis. Now let us look at acute cholangitis. When you have partial or complete obstruction of the ductus choledocus, when you have partial or complete obstruction of ductus choledocus, what do you have? You end up having a disturbance in the flow of the bile. The disturbance in the flow of the bile. Therefore, that bile begins to back up where? Into the cystic duct, that is the gallbladder, as well as into the hepar, into the liver. So when you have partial or complete obstruction, and you have now decreased flow of bile, as well as backup flow of bile, this increases the chances of bacterial infection. bacterial infection. So this bacterial infection only really happens when there is obstruction. Why? Because usually the flow of bile, as well as the presence of immunoglobulins in the bile usually keeps the bile sterile. But when there is obstruction, then the bacteria in the bile is then the bacteria accumulates. The bacteria accumulates, causing an infection, and that infection can lead to septicemia. That infection can be caused by E. coli. This bacterial infection can be caused by E. coli as well as Klebsiella pneumonia, as well as Strep ficalis, Enterobacter, Bacteroides fragilis. So you have these bacteria that cause bacterial infection in the bile, and this bacterial infection becomes ascending. So you have ascending bacterial infection, which then causes acute cholangitis. But you need to have both the obstruction, as well as the ascending bacterial infection in order for you to have cholangitis, acute cholangitis. So the bacterial infection alone is not enough. You need to have a combination of partial or complete obstruction coupled with the ascending bacterial infection in order for you to end up with acute cholangitis. So now you have the acute cholangitis. Now we understand how the acute cholangitis begins. What are the complications of the acute cholangitis? The complications of acute cholangitis are septicemia and the Reynolds pentad. But before we look at these two, let us first of all examine the Charcot's triad. Let us examine the Charcot's triad to understand the acute cholangitis. So now we know that there is inflammation. In fact, there is bacterial infection, and there is obstruction causing the distension, and because of the bacterial infection you have fever. Because of the bacterial infection you have the fever. Because of the bacterial infection you have the fever. Because of bacterial infection you have the fever. Moreover, because of the mechanical obstruction you have the jaundice. Because of mechanical obstruction you have the jaundice. And this jaundice, of course, you know, this is the conjugated bile that has been obstructed, and is therefore baking up into the liver. So you have jaundice end up accumulating in the bile, in the liver, as well as end up baking up into the blood circulation. So you have accumulation of conjugated jaundice, conjugated bile, conjugated heme, you know, the red blood cells are broken down into the globin part as well as the heme part, right? Heme part. So this heme then goes to the liver, and in the liver it is conjugated, right? When it's conjugated, then it goes into the bile duct, and when it goes into the bile duct, it flows to the choledochal ductus choledocus. But now when there is obstruction, you have now this accumulation of the conjugated bile, right? Conjugated heme, right? So that's why you have jaundice, yellowing of the skin, because of the accumulation of the hemoglobin of the heme, right? Now, bilirubin, that's it. Bilirubin, forgot such a simple word, right? Conjugated bilirubin, right? Let me write this here. Because of the conjugated, right, bilirubin. Yeah, you know that when the bilirubin goes from the blood, when the bilirubin exits from the blood, it goes into the Gepper, right? It goes into the Gepper, and then from the Gepper, it goes into the cyst into the gallbladder, and then from the gallbladder into the ductus choledocus, and then there it goes to the there you find the pancreas, right? And then you have your duct that goes into and empties into the small intestine, goes and empties into the small intestine, and then here you have the papilla of Vater. Papilla of Vater. And then when this bilirubin, this conjugated bilirubin, gets into the small bowel, some of it is reabsorbed, right? Whereas some of it goes into the stool. Some of it is reabsorbed, some of it goes into the stool. And here is a little mnemonic for you, something to help you remember this. So, sterco, right? Stercobilinogen stays in the stool. 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 Whereas the urobilinogen is uploaded where? Into the urine. Stercobilinogen stays in the stool. Urobilinogen is uploaded into the urine. All right. So because of the conjugated bilirubin that is accumulated owing to the mechanical obstruction, you now have jaundice. You have now jaundice. Because of bacterial infection, you have fever. And because of the mechanical obstruction, you now have the distension, the dilation of the ductus choledocus. Ductus choledocus. Because of the obstruction, you now have distension and dilation. You have now distension or dilation of ductus choledocus, and this causes backflow of bile into the duct, and therefore you have this distension that causes pain in the right upper quadrant. Pain because of the distension of the capsule, right? Now, that is Charcot's triad. So this cholangitis, if it is not treated in time, it can complicate and cause septicemia. As well as it can cause Raynaud's pentad. Penta means 5. Penta means 5. So Raynaud's 5 signs. 5 signs of Raynaud, which is also known as the intoxication syndrome. The intoxication syndrome which is comprised of fever, as you know, because of the bacterial infection. There is fever, high body temperature. Because of the mechanical obstruction, you have jaundice, the accumulation of conjugated bilirubin, and then because of the obstruction and backflow of the bile, you have right upper quadrant pain, and because of the bacterial infection, you have septic shock, and because of that, the combination of all this, you have mental status changes. So the patient becomes disoriented, as it were. All right, disorientation. All right, that is Charcot's trial and a review of cholangitis. Let us look at Schwostek's sign. Schwostek's sign is used to assess for hypocalcemia. It's used to assess for hypocalcemia. Now, what is this? This is really, it's not just that there is decreased calcium in the blood, but there is decreased ionized calcium. We'll look at this decreased ionized calcium and then understand what the Schwostek signs is all about. Now, when we talk about calcium in the blood, calcium in your body, yeah, if you are 70 kilogram, if you weigh 70 kilogram or somewhere there, you contain 1.2 kilogram of calcium in your body. So you are a walking block of calcium. Okay, so you are comprised of 1.2 kilogram of calcium. That is 1,200 grams of calcium, right? And 99% of that calcium is stored in the bone. 99% of the calcium in your body is stored as hydroxyapatite. hydroxyapatite in the bone. 99% of the calcium in your body is stored as hydroxyapatite in the bone. All right, what about the other 1%? Less than 1%, that is 5 to 6 grams. Less than 1%, that is 5 to 6 grams of your calcium in the body, is stored in the extracellular compartment outside the cells. Outside the cells, you have 1.3 grams. Whereas inside the cells, in the intracellular compartment, you have 3.7 to 4.7 grams. 3.7 to 4.7 grams of your calcium in your body is essentially found in the inside your cells. That is the total. This is the total. The total is 3.7 to 4.7 grams of calcium in your body is found in the cells. It's divided amongst your cells in the intracellular compartment. However, there is 1.3 grams, that is of that one, less than 1%. 1.3 grams are found in the intracellular compartment. Now, look at this. That intracellular compartment is made up of the interstitium. The interstitium. The interstitium is the space surrounding the cells, right? Space surrounding the cells. So that's where you find some of the calcium, but some of the calcium is found in the plasma. Some of the calcium is found in the plasma. Okay, let's look at that. This is where the money is, in the plasma. So when you go into the plasma, the total concentration of calcium in the plasma, is 4.5 to 5.5 milliequivalent per liter. 4.5 to 5.5 milliequivalent per liter. That is the total concentration of calcium in the plasma. That is roughly 9 to 10.2 milligrams per deciliter. Now, of that 9 to 10.2 milligram per deciliter of calcium in the plasma, you have 50% of it as ionized calcium. 50% of it is ionized calcium. We'll look at what ionized calcium is. 40% of that calcium in the plasma, 40% of it is bound to the proteins. 40% of it is bound to the proteins. And 10% of it is bound to the anions. 10% of it is bound to the anions. So 10% of the ion of the calcium, 10% of the calcium in your plasma is bound to anions such as phosphates, carbonates, citrate, lactate, and sulfate. Whereas the 40% of the plasma calcium that is bound to protein, 90% of that 40%, 90% of that 40% is bound to albumin, the small proteins in the blood, very important protein that maintain the oncotic pressure, All right. So, now, a few things change this ratio. A few things change the amount of calcium that is bound to the albumin. In acidemia, in acidosis decreases the protein bound calcium, whereas as alkalosis increases protein bound calcium. Alkalosis increases, acidosis decreases. Alkalosis increases, acidosis decreases the protein bound calcium that is bound to albumin. Therefore, when you have alkalosis, you have the decreased ionized calcium. Let us now look at that. When in the ionized calcium, it is when you have with respect to ionized calcium, when you have alkalemia, alkalosis in the blood, this causes the calcium that is ionized to decrease. Ionized calcium is decreased by alkalemia. And why? Because alkalemia causes more calcium to bind to albumin. So alkalemia causes more calcium to bind to albumin. Alkalemia causes calcium to bind to albumin, and as a result, the calcium that is bound to the ion as a result, ionized calcium is decreased. As well as a result, the calcium shift from being ionized calcium to being bound to albumin. All right. So ionized calcium is decreased by alkalemia because alkalemia decreases ionized calcium, and this decreased ionized calcium, when the ionized calcium is decreased, this is the only one that exhibits signs and symptoms of hypokalemia. It's the only one that exhibits signs and symptoms of hypokalemia. So if you have a decrease of calcium that is bound to protein, that is bound to anions, if you have a decrease in that aspect, then it does not cause signs of hypokalemia. Hypokalemia is only exhibited when you have decreased ionized calcium. Take note of that. Decreased ionized calcium. Decreased ionized calcium is what causes hypokalemia. Decreased ionized calcium is what causes hypokalemia, right? Whereas acidemia increases ionized calcium. All right. So now we know what causes hypokalemia. It's a decrease in ionized calcium. Ionized calcium causes hypokalemia. So now when you come to Schwostek sign, you are assessing for hypokalemia, which is exhibited by, which is a definition essentially of decreased ionized calcium. So because when you have hypokalemia, you have spasm of muscles. You have spasm of muscles. Therefore, when you tap the facial nerve, the facial nerve ends up twitching and being spastic. The facial nerve exhibits spasm and twitching of the facial muscles. So when you tap the facial nerve, it fires, and then it causes the muscle to contract, causing spasm and twitching of facial muscle. These are the cheek muscles. While we are at it, we may as well talk about Trousseau sign because it's the same. A decrease in ionized calcium. A decrease in ionized calcium. Right? And as a result, when you compress the forearm with the blood pressure cuff for 2 to 3 minutes, the patient develop carpal spasm. You have spasms of the arm spasms, jerks. You have jerking movements of the arm. Right. Okay, guys, that is it. We ended there today. So we have looked at Charcot's. We have looked at Schwostek sign. We have looked at Trousseau sign. We have looked at Charcot's triad. We have looked at carcinoid triad. We have looked at blue mass shelf. We have as well as looked at Beck's triad. We have also looked at Battle sign. We have looked at balance sign. We have also looked at Allen test. And next time we will continue with other signs and triads of in surgery. All right. So if you want to review, you can just replay this video and refresh your memory when you are doing your last minute reviews. All right. Thank you so much for watching this video. Again, like, share, subscribe, and we'll see you again in the next one. God bless you. Thank you so much.